Jeremy Wiggins once again. My pronouns are he and him, and we might kick off this evening by going to a video by Thorne, Harbour Health and Switchboard Victoria around COVID vaccinations. Awesome. Thank you so much. And once again, welcome to Get the Facts on the Vax. So a forum brought to you by Thorne Harbour Health and Switchboard Victoria. We're here to help inform community members from the LGBTIQ plus community around information on COVID vaccinations, side effects, and availability. So this is the perfect opportunity for you to listen to some experts, some people who work in community health, doctors, academics, all around the information that you might be interested in hearing about to be able to be better informed about COVID vaccinations. Once again, this session is being recorded and streamed live to Facebook. So we're going to go now to Dr. Jessica Kaufman, who's going to be able to provide you an overview of vaccines, side effects, and access and recommendations around COVID vaccinations. And over to you. And but yeah, there you go.
Thank you. Thanks, Jeremy. Welcome, everybody. Thank you for taking time out of your evening to come to this session. I hope that it's helpful for you. I hope it answers some of your questions. My name is Jessica Kaufman. I'm a research fellow at the Murdoch Children's Research Institute, and my background is normally in in vaccine communication. And I do normally a lot of research around childhood vaccines and pregnancy vaccines. But of course, like everyone, I have pivoted. So now we're doing quite a lot of work around COVID vaccines. So I will give you a bit of an overview, but before I do that, I just want to acknowledge that I'm joining you today from the land of the Wurundjeri people of the Kulin Nation and pay my respects to elders past, present, and emerging. So this presentation is going to be relatively whirlwind and short and may include some information that you already know, but hopefully it gives you a bit of a grounding about the vaccines and the recommendations and some of the safety and effectiveness information that you might be looking for. So this slide is really about the vaccine development process, because one of the main questions we hear from people all the time is a concern that the vaccines have been developed so quickly that people are worried that they must be unsafe. So this is just to show you that none of the steps in the regular development and testing process of the vaccines were skipped. What happened is that they were actually overlapped. So you can see on the top, it normally takes almost 10 to 15 years to develop a vaccine. And that's partly because they're doing all these different studies sequentially, but it's also partly because there's lots of time in between the studies where they're trying to raise money, recruit people for the trials, organize everything, get the manufacturers on board. There's tons of dead time normally. So in this case, the main thing that happened is that we were able to start collecting data about safety, and then we started collecting data about whether the vaccines caused an immune response, but we kept collecting that data on safety. So you can see that overlapping. The other thing is there was so much money and investment in this process that there was no downtime at all. And you can see that the production of the vaccines actually started before they were finalized, before they were approved. And that's because the vaccine manufacturers kind of took a punt and started making those vaccines, but they still went through the whole approval process they would normally go through and were approved by the Therapeutic Goods Administration in Australia, and then they were ready to roll out. And the thing I want to draw your attention to is that purple bit, ongoing safety monitoring. That's critically important. And that's where we are now. So even though we've rolled out these vaccines, we continue to collect all kinds of data about safety, and we're also collecting data from all over the world about safety. So I just want to reassure you that they were done quickly, but they were also done very rigorously and approved with all the same data as normal.
Jessica, if I can just interrupt, there's just been a question, if possible, if we could slow down the presentation, I think.
Sorry. All right. I might end up going more than 10 minutes, guys, but I'll
okay.
I'll slow down. Apologies. This is the coronavirus. So what you can see on the outside of the coronavirus, those little black tulip-shaped things, those are the spike proteins. And that's actually how our body recognizes the virus and how the vaccines that we have in Australia actually work. So the vaccines that we've got in Australia, you'll be pretty familiar with. We have two now that are mRNA vaccines, and that's the Pfizer vaccine, which we've had all year, and the Moderna vaccine, which is very new. You might hear it called Spikevax. That's a generic name for it. These vaccines work in a really clever and interesting way. So you can see in that picture, there's a little bubble, that's a little fat bubble. And inside the fat bubble, the little wiggly worm bit is a bit of genetic material. It's called messenger RNA. And what happens is the vaccine is delivered into your arm. That little fat bubble protects the messenger RNA and it travels into your cell. And your cell then reads that messenger RNA and it builds the spike protein. It's like a blueprint for building just one of those black tulip-shaped spike proteins. And then the messenger RNA is destroyed by your body. So it only lasts a few hours in your body. It can't combine with your DNA. It can't change your DNA in any way. It's purely just a little blueprint that your DNA can read and make that spike protein. And what that does is it allows your body to recognize the coronavirus next time it sees it, or if it ever sees it. So that's how the mRNA vaccines work. The other type of vaccine that we have in Australia is Astrazeneca. And this vaccine is what we call a viral vector vaccine. So similar to the mRNA vaccines, there's a bit of genetic information, but instead of coming in a fat bubble, this one comes in what is a killed virus, basically. So it uses that as a little transportation mechanism, and it can't make you sick. Neither of these vaccines have any live virus particles or anything like that. But it travels into your cell. Your cell reads that genetic material and learns how to make a spike protein. Again, that's how your body will then recognize the COVID virus if it sees it. These vaccines are really incredible. They work really, really well, which is amazing because a lot of vaccines that we use all the time are not as effective as these vaccines. There's a lot of numbers here, but basically what I'm showing you is that in the trials, the clinical trials, both the Pfizer and the Moderna vaccines were very effective. They were very effective at preventing any symptomatic infection, but importantly, they were also very effective at preventing severe disease and death, which is the main outcome that we're looking for from these vaccines. You can also see that both of these vaccines have been tested in children aged 12 to 17, and they were really effective in children as well. And that's why just recently we've gotten approval to deliver these vaccines to all kids over 12 in Australia. So there's a difference between what you see in a clinical trial setting, even though those trials have 30 or 40,000 people in them sometimes, versus when you roll it out into the real world and you have billions of people. But really promisingly, really positively, both of these vaccines have also performed really well in the real world, even against the Delta variant. So what you can see is that if you've got 2 doses of the Pfizer vaccine or the Moderna vaccine, you get really good protection from severe disease, even with the Delta variant out there. Now, both of these vaccines also reduce transmission. So the ability for you, if you do get sick, even though you're vaccinated, you are less likely to pass it on and to make someone else sick. Now, the reason I don't have a number there is because most of the studies around transmission were done before the Delta variant came out. And unfortunately, Delta is very transmissible. So what we're seeing is you are much less likely to get sick, and you are less likely to pass it on if you do get sick, but the chances aren't zero. So that's why it says just reduced there. The Astrazeneca vaccine has gotten a really bad rap in Australia, but actually it's also a really effective vaccine. So in the clinical trials, it looked a little bit less effective than Pfizer, but then they sort of figured out that it was more effective if you gave a longer gap between the two doses. But then once it's been rolled out in the real world, it's actually almost exactly the same as Pfizer and Moderna in terms of preventing serious disease, hospitalization, and death. So 2 doses of AstraZeneca are also really, really good at preventing Delta. And it also has similar prevention or reduction in transmission. So that's how well the vaccines work. But then if we want to talk a little bit about how safe they are, this is a really important question a lot of people have. The first thing to know is that it's very likely that you will have some kind of side effect from any of these vaccines. What we sort of expect for side effects for these vaccines are a sore arm, that's what we call a local adverse event or a local reaction, or things like a headache, tiredness, aches and pains. Those are what we call systemic adverse events. These happen more often after the second dose of the mRNA vaccines or the first dose of the AstraZeneca vaccine. We see sort of similar rates in children who've been vaccinated with Pfizer and Moderna. The important thing about these side effects, though, is that they don't last very long and they are not serious. So on the right, you can see a picture. In Australia, we have a system called AusVac Safety, which monitors all the side effects that people are experiencing from vaccines. It sends a text message to a number of people after they get the vaccine and asks them what side effects they've had. So what you can see is 55% of people in Australia have had no side effects. 45% have had some side effects, but less than 1% have had to go to the doctor or an emergency department. So these side effects are not generally serious. Some people do have a serious reaction, an anaphylactic reaction. That's when you have sort of a severe allergic reaction right after getting the vaccine, but it's pretty rare. Normally with vaccines, we see it in 1 in a million people. It's about 3 to 5 in a million for Pfizer and Moderna, and also 1 in a million for AstraZeneca. Now, the main serious side effect that we have found is the clotting syndrome that we've seen associated with AstraZeneca, which I'm sure you've all heard about. So that's thrombosis with thrombocytopenia syndrome, and that means clots, that's thrombosis, with bleeding or low platelets, that's thrombocytopenia. It is scary. It can be very serious, and we have seen 8 people really tragically die from this syndrome in Australia. However, it is also very rare. So there have been about 13 cases of TTS per million people who have been vaccinated with AstraZeneca. We also are very aware of TTS now, and we're treating it quickly, and really people are having much better outcomes generally. The only risk factor for TTS is younger age. So it does not matter if you have a history of other types of blood clots or stroke or heart disease or low platelets, or if you've been on blood thinners. None of those things make you any more likely to have TTS. It's not linked to the mRNA vaccines. It's only linked to AstraZeneca. And because it is more common in younger people, that's the reason for the recommendation that AstraZeneca is for people over 60 preferred, and Pfizer and Moderna are preferred for people under 60. There is also a side effect that you should be aware of with the mRNA vaccines, and that's myocarditis or pericarditis, which means swelling of the heart or swelling of the lining around the heart. Now, this is also quite rare, and fortunately, it's not nearly as serious as TTS. So we've not seen any deaths associated with myocarditis or pericarditis. It does appear to be more common in younger people, and particularly in young men. So the age group with the most highest risk of this are young men 16 to 17 years old, but it still only happens sort of 1 in every 16,000 cases in that age group, and much less commonly in other age groups and in women. So it's something to be aware of. It can present as chest pain or irregular heartbeat or shortness of breath within the first 10 days after vaccination. Some people will go to hospital for treatment, but everyone pretty much is no one has died, as I said, and you are discharged usually within a day or two. Now, the recommendations have changed a lot. I know it's confusing, and it's in reaction to the safety data, and that's important. I think it's good that we change our recommendations based on safety data. However, it can be hard to follow. So this is a summary. There is no vaccine currently approved for children aged 0 to 11 years, although it is likely we will see one in the next sort of 6 months. For children 12 to 17, they are eligible for Pfizer or for Moderna. You can get Moderna through pharmacies, and it's just started this week, so that will ramp up. For anyone 18 to 59, your recommended vaccine is Pfizer or Moderna as well, but you are eligible for Astrazeneca. You just have to have a conversation about the risks and benefits if you do choose Astrazeneca. Anyone over 60 is recommended Astrazeneca. And at this stage in Victoria, there are no plans on the books to open that to Pfizer and Moderna. So we really recommend people over 60 to go ahead and get AstraZeneca because the risk of COVID in that age group is really serious. The current spacing between all brands is 6 weeks. That has changed back and forth. You have good protection from all the brands. It does not change how effective they are, does not change how safe they are. It is purely the sort of a logistical decision mostly. If you've had the first dose of AstraZeneca, you are very unlikely to have a reaction TTS to the second dose. So we really recommend that people go ahead and get that second dose. Currently in Australia, we are not recommending or offering third doses or boosters, even for immunocompromised people. But it's likely that that will be considered next year at some point, and the people who would be prioritized for that would be people who are elderly or people who are likely to have had a lesser immune response to the original vaccines. We also don't currently allow or recommend mixing brands for most people. So you will get the second dose of whatever you got as the first dose. The vaccines are safe for people who are planning pregnancy and people who are breastfeeding, and anyone who is currently pregnant is recommended to get either the Pfizer or the Moderna vaccine at any stage in pregnancy. So those vaccines are safe in pregnancy, they're safe for the baby. There have been studies, observational studies with 35,000 women in the US that have informed that decision. And it's just important to remember that COVID itself is much more dangerous in pregnancy and can lead to premature delivery and a number of other nasty outcomes. For people planning pregnancy, there is no evidence at all that any of the vaccines affect fertility in any way, and thousands of people have become pregnant since being vaccinated. They do not affect sperm count in any way, and in fact, COVID itself has more of an impact on potential fertility with, potential erectile dysfunction associated with COVID infection. So, it's really weighing up the disease itself against the vaccine, and the vaccine is much, much safer and has no indication of any implications on fertility. It's also safe for people who are breastfeeding currently, and it looks like some protective antibodies might pass through the breast milk to also offer a bit of protection for the baby. So that's 2-for-1 protection. The takeaway messages are really just to remember that more than 6 billion doses of these vaccines have been delivered around the world. So we are just a drop in the ocean, and we're collecting data on all those vaccines delivered elsewhere as well. So we are constantly monitoring for safety, and it's not surprising that we have found some rare safety events. No medication is without any risk whatsoever, but it's really reassuring that we're acting to respond to those safety events, and that's where you see those recommendations changing. Information is going to keep changing. That's the nature of the pandemic. So that doesn't necessarily mean that there is something untrustworthy about it. But I would encourage you to be a bit cautious about media headlines. They often are sensational and maybe not accurate. And absolutely, if you have any questions about the right vaccine for you or any specific things about your medical conditions or medical history, I highly recommend that you speak with your GP or a specialist and have that conversation with them, with someone who knows your medical history. So I'd like to end there and acknowledge some of my colleagues who have helped put this together, and of course, the Victorian Department of Health, who supported the development of this slide deck. That's for me. Thanks very much.
Thank you so much, Jessica. That was fantastic. And I'm sure everyone paying attention learned a lot and got a lot of facts on the vax from you right then. Thank you so much. And we may encourage people again to use the Q&A function if you have any questions, because this is the perfect opportunity to get those questions answered. So thank you again, Jessica, for that. That was fantastic. Right now, I want to introduce our panelists to you so we can get a conversation going, and again, encourage you to use the Q&A function to ask any questions. Our first panelist is Dr. Ada Cheung, and is an endocrinologist at Austin Health, and is also part of the Trans and Gender Diverse and Community Health Initiative in partnership with Your Community Health, Ballarat Community Health, and Thorne Harbour Health, and is also the lead of the Trans Health Research Group at the University of Melbourne. And we've also got Dr. Nate Reid, who is an accredited prescriber of HIV medications, opioid substitution therapy, and has been providing gender-affirming access to hormone therapy under the informed consent model since 2017, and is based at Northside Clinic and the Victorian Aboriginal Health Service. And we also have David Tarnda Copley, who is an Aboriginal man of Kaurna and Peramung, I hope I pronounced that okay, descent, and is a recognised elder of the Kaurna Nation of South Australia. Welcome. And David holds a diploma in applied science, a Bachelor of Nursing, and a postgraduate in mental health nursing. David is the only Aboriginal person in South Australia to hold all three qualifications. David is the Indigenous Academic Advisor at La Trobe University, who holds positions of Chair on the Congress of Aboriginal and Torres Strait Islander Nurses and Midwives, and on the Reconciliation Plan Committee for the Australian Nursing and Midwifery Federation in South Australia, amongst several other high-level appointments across the country. As an Aboriginal elder, a registered nurse, mental health nurse, and a senior academic at La Trobe Rural Health School, his work takes in the communities of Bendigo, Shepparton, Mildura, and Albury. We are so fortunate to have all three of you here to join us on a panel this evening. Thank you for joining us and taking time out of your evening to be able to support our communities to better understand information and access to COVID vaccinations. Welcome.
Thanks for having us, Jeremy.
So if it's all right with you, we might just get cracking, and I might start. Yeah, and hi Nate, and hi David and Ada. I've got some questions for you, so I might just start directing them to you, if that's okay. So first question for Nate. How can trans and gender diverse people get vaccinated with their chosen name rather than their dead name? If they have their Medicare card that still has their former name or their birth name or their dead name, but they're registering to get a vaccination, what's the best way that people can get vaccinated in that situation?
That's a good question. Because unfortunately, because the Medicare, because of the way that the COVID vaccination certificate is linked to your Medicare, to the Australian Immunisation Register, I'm actually stumped. Great. Yeah. First question. I'm not sure.
No, sorry to throw the hardest one out there, where the entire public health system hasn't quite caught up to trans people and their names, but maybe perhaps the best place would be to go to a trans-friendly clinic. So at least there's some trans sensitivity and affirmative practice there to support people. So perhaps Equinox, Your Community Health or Ballarat Community Health, it does depend. So yeah. Perhaps some strategies around that might also be, because I personally, I'm a transgender man, and I went to one of the max vaccination sites at one of the northern hospital sites, but my name does match my Medicare card. But if I perhaps didn't have that situation, I could maybe take a letter and hand it to people. So at least there was a way to communicate to people that this is my preferred name, and that might be a strategy to help at least alleviate some anxiety for people in that situation. All right, next question for Ada. Are there any additional side effects or concerns for people going through menopause?
For menopause in particular, there isn't any link. So there's no link with higher side effects if your sex hormones are low, which usually happens at menopause. And there isn't any link between any kind of hormone therapy either. So if someone's on HRT, there's no increased risk of blood clots with any of the vaccines relative just because you're on hormone therapy above the general population.
Okay. All right. Thank you. David, I've got one for you. What about issues for Aboriginal and Torres Strait Islander communities with underlying health conditions? Can you speak to any potential?
I think our biggest, and is my headset working okay?
Yep, got ya.
Right. And hi, Nate, how's Buzz? Right, I think, look, and Nate might want to come on board here as well. I think one of our biggest problems is not uptake by our Indigenous population, but rather once you get outside of regional centres is the availability. We've been pretty good at promoting vaccination. And at one stage in Victoria, we had a higher vaccination rate than the mainstream Victorians. That's probably shifted a bit now. But in the early stages of vaccination, our vaccination rate was actually higher. But I think, and it's kind of a federal government thing, hate to point the finger at somebody, that they didn't think about how, because most of this stuff is refrigerated and frozen or whatever the vaccine happens to be. They didn't work out how they were going to get it to communities outside of major regional centres. And that's where we're starting to get, particularly in New South Wales and other places, vaccination rates being 6 to 8 weeks behind. And I don't see that as the population not wanting to have the vaccination, although there is a couple of people in the Indigenous community running what I call Clive Palmer campaign. And I discussed this with the department today, in that it's a white government plot to exterminate Aboriginal people. We've tried to take steps to get that off Facebook because it had quite a few hundred followers. But I think it's more of a supply issue than we don't want to take it.
Yeah.
I don't know what you think about that, Nate, but that seems to be.
Thanks, David. Do you have any further to add to that, Nate?
Yeah, I think in terms of Indigenous communities, I think has been really, really good uptake. I know at VARS we're kind of doing sort of about around 500 vaccinations a week. And I guess in terms of sort of accessing, if you are Aboriginal or Torres Strait Islander, it doesn't matter if you've never been to like a service like the Aboriginal Health Service, Victorian Aboriginal Health Service, you can come and get a vaccination there. But the other thing you can do is you can always call up and say that you want to have a discussion about the vaccines, and the health workers, the nurses, the doctors are all more than happy to sort of have a discussion with you if you've got sort of very specific concerns as well. But yeah, so there's vaccines available, and it's just about sort of reaching out and getting them.
And I think the other interesting thing with some of the art shows in some of the regional centres is that they're saying, hey, we don't care if you're black, white, pink or brindle. We're happy to vaccinate you if you want to turn up at our service. So they have really engaged with their whole community. I think that's been really good for art shows, and I think it's been really good for communities because they get to see behind what actually happens behind those doors of the Aboriginal Health Service. Yeah, so that's been an interesting side event, I think.
Yeah, and I definitely saw media profile of how Aboriginal communities really led the way around supporting their communities and getting huge uptakes of vaccinations. So that was fantastic to see that community-led, community-controlled initiative. We have a question from the audience, and I might just open this up to the whole panel. In your professional opinions, do you believe vaccinations should be mandatory in order to get our desired targets and return to a semi-normal life?
I might kick that off in that I'm a couple of years older than some of the other panelists. So I've lived through stuff with whooping cough and diphtheria, and I saw people who were born before me with polio and tetanus and a whole range of things like that, which they made mandatory, particularly in children. So I think once we get the children's vaccine up, I can't see why that can't be added to the other vaccines that we just consider to be normal. The interesting thing is that once upon a time, if you went overseas, you had to have a vaccination from everything from cholera to a cold just about. When you came back from Bali, they sprayed you on the plane. And that was mandatory and nobody complained. So we don't make flu mandatory, but we have certain vaccinations, particularly in young age groups, that are mandatory, and I can't see why that's not an issue. Adults are. Children don't have the ability to say yes or no, and so we kind of need to leave them. In adults, I guess we still give them the preference. I don't know what Ada thinks about that.
Yeah, Ada, do you have a comment on that?
Yeah. My general approach is not to mandate things on people. And I personally, I try and educate or understand where people are coming from to get them to maybe understand, what makes them tick and why they've decided to make that decision. And particularly people who are very reluctant, sometimes if you force them to do it, you sort of get people's back up rather than get them to change behaviour. And we've sort of seen that a bit with the construction industry in Melbourne in the last few days. When you force someone to do something, sometimes the immediate reaction is maybe they're not even opposed to vaccines, but the pure fact that you're forcing someone to do something sort of sparks a reaction. So, I don't have strong feelings either way, but, a general approach is to try and engage people to motivate them to make the decision for themselves.
Well, I guess on that, Nate, working in VARS, I mean, and David and Ada, you all work with vulnerable populations, and I guess around boosting the vaccine uptake is really about also ensuring that there's not a huge pressure and burden on the health system and all the people working in that space, and that there are enough resources to be able to support people who have these complex underlying health conditions. Do you sort of see examples of this in your professional roles in the health service, the impact perhaps of people being hesitant or reluctant to get vaccinations, and what they might need to be encouraged to get them?
I think, I don't know if I'm jumping in ahead of you, Nate. I was going to say on this mandatory thing, I think mandatory is probably a really strong word. I mean, our childhood vaccinations are kind of mandatory without being mandatory. But I think what I'm seeing in the Indigenous population, and that probably flows across in communities to other minority groups, is that they're really in favour of things like, if you haven't had a double vaccination, then you can't come to our event, because they're community health orientated. And I think this is what you might see more in regional settings. Like if you come into the regional towns that I deal with, there are so many shopkeepers who say, I want to see your driver's license. We haven't got to asking for a vaccination passport yet, but right now they're saying, I want to see your driver's license before you come into my establishment. So I think in communities, we're going to see more of that in the regional centres, and particularly within the Indigenous population. I don't know how that goes with you, Nate.
I guess in terms of thinking about vaccination, so the mandatory word, I think, is the thing that actually sort of is a little bit jarring, and I think that that's the thing that people kind of really react to. And I think that a better way of kind of framing it is thinking about that kind of that we're never going to hold people down and force them to have a vaccination. However, so similar to sort of how David sort of talked about when there was, for international travel. So there's certain places in the world that you need to have evidence that you've had yellow fever immunization to actually get into the country. So it's more around thinking about it rather than we're going to make every single person have the vaccine. If you don't have the vaccine, there might be consequences, and that those consequences might be that you can't go into certain like healthcare facilities, or that you can't go to the shop, or you can't go to a concert that you really wanted to go to. And that's that, it's sort of thinking about it. The other part of that is that, it's not actually just about you, but it's about the sort of the people that you might be interacting with. And you don't know if somebody that you're interacting with has a reason that they haven't been able to have the COVID vaccine, or they do have one of the very sort of rare medical exemptions that they can't get vaccinated, and you're potentially putting them at risk by not getting vaccinated and then going and interacting in those spaces. So it's more around that kind of, rather than thinking about it as we're going to hold you down and vaccinate you, it's more about you might just have some more restrictions if you don't get vaccinated, and sort of being aware of that.
Yeah, I think Nate's right there. And particularly, I think we're going to see regional communities, remote communities. I mean, if you look at remote communities, Aboriginal and say nobody in, nobody out, they were very quick off the mark. But I think in regional and remote communities, and I think in minority communities, things like the gay community, that you're going to see them as leaders in this. If you haven't had a double dose, then you're not going to be able to join in as much. And I think Aboriginal, regional communities, yes, but I also think minority groups like Aboriginal, Torres Strait Islanders and the gay community are probably going to be far more in the leader role of that type of.
Yeah, thank you.
Stopping.
Yeah, thank you for that. And I got a two-pronged question for people who might be Medicare ineligible, so they haven't got a Medicare card yet. Can people without Medicare cards get vaccinated, and where can they be vaccinated? Ada or Nate?
I believe you can get if you don't have a Medicare card, you can still get a COVID vaccine, and you can get if you go, perhaps we might put a link in the resources at the end, but you can apply for an individual healthcare identification number. So if you already have a Medicare card, you already have an individual healthcare identifier. But if you don't have a Medicare card, you can still apply for one. And you can do that, online. And you need that just for proof of your vaccine. You don't necessarily need it to get the vaccine. The other thing is, if people do want to change their Medicare card name, that's a process that you can do that's actually not too difficult to do through Medicare offices or online. And there are links on various websites for trans people who want to change their Medicare card.
Yeah, so there'll probably be information on Transgender Victoria's website or Trans Hub.
Trans Hub, yeah. And there's even a letter on Trans Hub that you can download and print and take it with you to the COVID vaccine place and say, it explains, please use this name and not my dead name, even though it might not, be reflected on my Medicare card. And also international students can get the vaccine for free. So basically the government's just trying to get everybody, regardless of whether you've got a Medicare card, vaccinated for free.
So for people...
I think if I'm right, you can correct me, that if you don't have a Medicare card, which is going to, your Medicare card logo on your phone is going to give you like shows you how to double dose. You can actually get a card from the vaccinators saying that you've had double dose. I think that's correct, but I might be wrong.
Well, for people who don't have Medicare cards, there's obviously a number of ways that people can get vaccinations through a GP clinic, and whether that's a private or a bulk billing clinic, or a state-run facility. And so for people without Medicare cards, is there a better route for them to book in to get a vaccination?
Are you requiring a Medicare card at VARs? I know when they go into the remote communities, having a Medicare card might be something they've never seen. They're just vaccinating everybody. But for Aboriginal people who rock up at your clinic and they don't have a Medicare card, I assume you still vaccinate them.
Yeah. So we definitely still vaccinate, and we just try and find that. I think we just try and find those Medicare details or the individual health identifier number so that we can still link it, because it's more around just making sure that they can link it to have their vaccination certificate, official kind of document.
All right. I might move on to another question related to HIV. When we hear the word undetectable in relation to HIV and that the virus can't be passed on, does the same apply for COVID? Could there be people who have the virus but are not able to pass it on? Nate, perhaps you could answer that one. I
suppose it's a little bit different. So they're both viruses, but if you do have COVID, if you are tested positive for COVID, then you do have viral load. So you don't have an undetectable viral, you can't have an undetectable COVID viral load and be COVID positive, if that makes sense. So it's a little bit different. And so when we're talking from a HIV perspective and we're talking about an undetectable viral load, what we know is that with the medications, they're reducing the amount of HIV in the body and in the system to a level that we can't actually detect, but it is still in the system. It's just suppressed. As opposed to COVID, when we're testing you for COVID, we're actually testing for evidence of the virus, the DNA of the virus in your system. So you can't be undetectable. If you're undetectable for COVID, then you don't have COVID, or you've cleared COVID, if that makes sense.
Yeah, thank you for that. I have another question, and anyone can answer this one. If I am not in a local government area, an LGA of high concern, should I bring forward the date of my second Astrazeneca dose to 6 weeks or wait for the 12-week mark?
I mean, I think that the guidelines around Victoria broadly is that we should bring it. So you should bring it to the 6-week mark. And I think the way of thinking about it is unfortunately the way that these outbreaks have been happening is that you don't know whether your local government area is going to be an area of concern in 6 weeks' time. And so if we get everybody immunized earlier, then it's going to create a little more kind of protection for the individuals. So it's Victoria-wide recommendation to bring forward that vaccination so that we get that rate of double dose quicker, and so then we've got more immunity within the community.
Okay, thank you. And we've just had a comment come through as well around name changing on Medicare. It can also be done over the phone with supporting documents, and you can look at that online through servicesaustralia.gov.au, and it is a fairly simple process. I'm not sure of how quick it is. It could be instantaneous or maybe a couple of days. Does anyone know how long it might take to change your name on your Medicare details?
I think they can change your name instantly, but they can't. Online on their website, it says they can't change the gender instantly. So they can change the name instantly, and they might give you a number that you can use But the physical card won't arrive for like 3 or 4 weeks.
Okay. Now I can see, Ada, that you might be typing an answer to a question, but I might ask you this one. Someone's asked us live on the session, is shedding a real thing after the vaccine? I have had people say that I am not welcome at their home as I have had the vaccine and I may be shedding, which was quite upsetting for the person.
Yeah, understandably, it sounds quite upsetting, and particularly so because it's not correct, and because the vaccine doesn't contain any live virus. It's impossible to get the COVID infection from the vaccine. And after you have the antibodies, you don't shed the virus at all through your skin or urine or saliva or anything like that. I believe Nat or David might know more, but I believe people who actually have the COVID vaccination, they can shed virus through their poo and secretions and things, but certainly not from just the vaccine.
No, it's not from the vaccine, but we get, and that's one of the trace things through wastewater is looking for shedding in LGAs, because if they get just a little bit, they don't worry, but if they start to get a build-up of shedding, say, I don't know, pick on a suburb, Moonee Ponds, then they will go in and have a closer look. So we had a little bit of shedding in Bendigo at one stage, but it vanished. So it must have been, it could have been somebody passing through, and that showed up in the wastewater detection. And we had a little bit here in Bendigo after that last case, and it was gone. So, but I haven't heard anything about shedding from having the vaccine at all, because it's not live.
Thank you for that answer. And I might go back to HIV again. Are there any interactions for people living with HIV and vaccines? And is there a vaccine that's best for people living with HIV?
So there's no, so broadly, there's no contraindications to any of the vaccinations if you are HIV positive or on any of the HIV medications. And so essentially the vaccine that you should get is the one that is available to you. And in particular, if you are HIV positive and you do have a detectable viral load, or your CD4 count, so your immune system is compromised, so it's below 200, then it's even more important that you get the COVID, whichever COVID vaccine you're able to get, because you are potentially at a higher risk of getting quite unwell if you were to contract COVID.
And I think that there's another case for that within the elderly. So I have a 90-year-old mother who we finally got to have both doses, but she wouldn't have it. She wouldn't have the second dose because, oh, I must be allergic to it because my arm went all red and swollen. And she won't have the flu vax for that same reason. And it's been one hell of a journey. She's double dosed now because they think because I get a sore arm and look, newspapers are horrible things in this country. The media is terrible. That I'm allergic to it and I will get a blood clot and die. You know, I think our media, unfortunately, the media in this country really overemphasizes without the stats. Like, you know, we've had 1,500 cases in New South Wales. What they don't show is that's 0.0001% of the population. You know, they don't deep dive. It's just a blurred. My God, 12 people got blood clots. We're all doomed. So I think, you know, we all need to be very cautious about what the media puts out as to what's actual fact. And that impacts on elderly and our communities as well within Indigenous. And I'm sure that has the same impact on HIV communities and other communities. That
yeah, it's a good point, David.
It goes with your head.
It's a very good point that we we've kind of been coming up to almost like an 18-month to 2-year mark of being saturated by daily news around COVID, and a lot of the media can be quite sensationalized, sometimes not evidence-based, and, you know, fear-mongering. So it is really important that people access evidence-based information, speak to their GP. This session is really helping. And I also encourage people to continue asking more questions, because this is the perfect opportunity to have people answer them. I'll go back to HIV again, if that's okay. So due to the sense of urgency caused by this pandemic, do you believe soon we will also have a vaccine for HIV developed to help our community?
There are some sort of precursor early vaccine type trials sort of happening, and it's sort of an evolving research space. I would like to think that eventually we will have some form of vaccination with HIV. It's a different virus, and it is quite challenging, I suppose, to sort of develop a vaccination for. On the flip side, we have really good treatments available for HIV. So you know, people can live long lives if they're HIV positive and on the medications that have relatively few side effects now. So, you know, I mean, who knows what's going to be possible in the future? I'd like to say that there's definitely going to be a vaccine for HIV, but I can't say that. But it is a space that there is research happening.
Thank you. We're getting lots of questions now, which is great. Please keep them coming. That's what we want. We want to be talking and answering your questions. Another question's come through. Is it likely that we will have to have COVID boosters for the rest of our lives, similar to, I guess, like the flu shot that people need to get annually? It's anyone's game here. Ada?
I think the science isn't clear yet. Like Israel, where they vaccinated a lot of people with Pfizer, I think they showed that over time the immunity, or that maybe it's the antibodies wane over time, but then it's not clear whether, even if those antibodies wane, it seems like people are still protected from severe illness and hospitalisation. It's not clear. I don't think it's at the moment, but there's more evidence to come.
Thank you. Does anyone?
I wonder if it's going to come down. If we look at the 1918-19 Spanish flu, and if you go back and look at all the documentation in Australia from that, what the federal government and the states have done exactly what they did back then with border closures and masks, and then they got to a point where we're getting to now where they said, well, we can't keep this up, we're all going to go broke or mad or something, and they opened things up. And pretty much every flu variation since then has been a variation of that flu, and we vaccinate against the variations. Now, whether that's going to be the same with COVID, I think as Ada said, you know, the science is a bit out on that at the moment because we haven't had it long enough. So I think we're kind of we're not quite at that point, we're kind of jumping the gun a bit.
Yeah.
Okay. You know, the main thing is let's get vaccinated now and let everybody, the science, catch up with the rest of the world. And that's what happened from the Spanish influenza. It just kind of, the science caught up as it went along.
Thanks, David. There's a question here, which I think, Ada, you might be best placed to answer because you've done the work on developing fact sheets around this. Trans guys, so trans masculine people who start testosterone are told that there's an increased chance of blood clotting with the testosterone therapy. Does this mean with Astrazeneca, trans masculine, trans people on testosterone would have higher rates of the risk of blood clotting?
That's a really good question. And it's trans guys are told that, but also people starting estrogen, so any kind of feminizing hormones as well, are told that there's a high risk of blood clots. But the blood clots that happen with Astrazeneca that Jessica described are different. So, you know, Usually blood clots form from, say, high hormone levels because the bloods are more sticky, it can more likely to clot, and it tends to increase the risk of things like DVT or deep vein thrombosis, like clots that occur in the legs that can sometimes travel in the blood vessels to the lungs and called PE or pulmonary embolus, a bit like when people travel on long plane trips, for a long time without moving their legs, they can get blood clots. But the blood clots that occur with Astrazeneca are this funny immune regulated thing. So it's not the same mechanism. It's some immune reaction to the vaccine that causes this unusual type of clotting with low platelets. And they get not the DVT and the PE that we know is associated with hormone therapy, but these clots in unusual places, like in the tummy or in the brain. And we know that the mechanism is completely different to the usual blood clots that happen with hormone therapy. And they've studied even people who've had DVT and PE in the past. They're not at higher risk of this TTS, this AstraZeneca type of blood clots, because they're completely different phenomenons. So it's safe for any trans person on hormone therapy. Being on hormone therapy like estrogen or testosterone doesn't increase your risk of this rare TTS. But in saying that, having COVID-19 infection itself, like if you are infected with COVID-19, the risk of TTS is much 8 times higher than getting it with AstraZeneca. So I think just thinking about the potential risks with the vaccine and the risks of having it with actually getting COVID infection, the risks with AstraZeneca are really low, and it's not higher in trans people on hormone therapy.
And if people want more information on that, we might share in the chat the links to the fact sheets that you developed, and they're also available on your Community Health's website as well.
Can I just jump in there, Jeremy?
Please do.
Because I'm on hormone replacement for the simple fact that I had large doses of chemotherapy. I'm a straight guy, but that doesn't matter. I had lots of, it killed everything.
Mm-hmm.
And I didn't get blood clots, so I didn't die. I had both injections of AstraZeneca. The downside, as Ada said, if I'd got COVID, it's been a long time since I've had chemo, but that still doesn't matter. The downside could have been far worse. But I'm on regular hormones, and I had the AstraZeneca, and I didn't turn into a giant blood clot. I'm okay.
Yeah. Well, I'm glad to hear it. And same, I'm on testosterone therapy, and I had Pfizer, and my side effects are really minimal. I felt tired. I actually had an afternoon nap, and I can never even do that. So I was grateful for that. And then my arm was a little sore for about a day, and I didn't even notice that until I kind of just touched it. So the side effects, I'd do it again. It didn't concern me. But there was a question, well, it's just disappeared, but that's okay. An important question though, for our communities, LGBTIQ plus, people living with HIV, where would be the best place where they can get vaccinated, where people might be fearing being judged for being queer, for being LGBTIQ plus, for living with HIV? Where can we go?
I think that a good first port of call is if you see a GP, if you're linked in with a GP that you know and you trust, then I would sort of start with them and ask them for specific recommendations within your area as to where they might be able to offer you the vaccination themselves, or they might be able to sort of direct you to where other people have been. And then it's sort of asking sort of friends, family, community members where they've gone, and just sort of word of mouth, whereas like with anything, whenever accessing any kind of healthcare as that's going to be sensitive, sort of ask your friends, ask your mates where they've gone.
Yeah, that's a good point. And I do believe there's going to be some increasing efforts and collaboration between community health services and Thorne Harbour Health, and some mobile vaccination clinics between your community health and Thorne Harbour Health. So do contact services and check, you know, your local LGBTI organisations and any community health service that's offering vaccinations, where there could actually be an LGBTI program in that health centre as well. I'm going to go back to a question that someone asked us in the audience around any adverse effects with the vaccination and cancer treatment. So David, you disclosed and shared generously with your experience.
So that was the first question I said to my oncologist, and I think I'll just add, I'm 10 years free, but I had I had a treatment they wouldn't do anymore. I had chemo 6 days a week for 9 months without a break because my cancer was pretty extensive. So the first thing I said, I rang my oncologist and I said to her, I don't know about this Astrazeneca rubbish because of this chemo history, because chemo stays in your body for a very long time. It doesn't go away overnight, and the whole thing. So we had and she said, look, to be very honest, all the evidence we've got is that have a vaccine, because COVID, particularly if you're going through treatment or if you've just finished treatment or in the first 5 years, the COVID's going to cause you far more damage than what might happen from a vaccine. And I think that's the big thing. I mean, I do a lot of work in the cancer space with Indigenous populations throughout Australia and get the vaccines because having the COVID's going to be far more detrimental. If there's a higher risk of going, very high risk of going neutropenic, winding up in hospital, being on a respirator, the whole gamut. If you're in treatment and if you get it, you've got to stop your treatment. So the risk in that area, all of a sudden, you know, your treatment's there. If your treatment's down for 3 months because of COVID, it just doesn't. Others separate out of the time period between people and when you can get vaccinated. From what I had from my oncologist, just get vaccinated. But if you have any doubt, talk to your oncologist because they will. You may have some special. You may be having a special leukemia treatment, which has arsenic and all other poisons in it, that may prevent you. Talk to your oncologist, but COVID's going to do more damage and could stop your potentially stop your treatment.
Yeah, thanks, David. And I used to work at the Cancer Council, and they have a fantastic team of cancer nurses who can provide phone support. And I'm certain that if anyone had any concerns, you could call the cancer nurses support line at the Cancer Council, and they'd probably be able to provide lots of information if anyone wanted to find out more about that. Thank you, David.
Can I interrupt there, Jeremy? Were you at Cancer Council Victoria?
Yes.
I worked for many. I was at Cancer Council South Australia, but I worked on the National Indigenous Tackling Tobacco Program for many years with Tom Karma.
Oh yeah, I've met Tom, and I worked with Jethro. But so let's catch up another time and talk about that and all those lovely people. Thank you. I want to cover PrEP because lots of our community members are on PrEP, and I want to know if there's any negative interactions or risks around getting vaccinated for COVID and being on PrEP.
So there's no interactions with PrEP and with any of the vaccinations. So it's completely 100%, you know, safe to be on PrEP and be getting vaccinated. So it's similar to, you know, all other HIV medications that none of them are contraindicated with any of the vaccinations.
Okay, that's very good news. I want to cover off another question around people living with a disability. So if someone's living with a disability, is there anything that they need to be aware of? I know that's the broad term and it could cover off a lot, but what are some tips or strategies or anything to consider for anyone who might be living with any kind of disability?
I'm probably going to jump in there because my background's in disabilities as well, unfortunately.
You're perfectly placed for it.
Look, I'm going to say that from my experience in the disability field, unless you've got a medical history, and your general practitioner can tell you, that says you can't have vaccination, then there's no more risk to you than any other population. There's no more risk if you're a paraplegic or a quadriplegic, or you have Down syndrome or autism or any of these things. I mean, unlike some people say, vaccination in your 16-year-old is not suddenly going to give them autism. So we're in the, and it's a bit like, why do we separate LGBT and disabilities and all of that stuff, or Aboriginal people or whatever? I'll come back to Shana in just a second. Hang on to that question for me, Jeremy, if you can. I saw it flash up.
Yeah.
I don't. It only affects you, the vaccination, if you have a legitimate medical reason where your GP or specialist says, no, sorry, you can't have this. Other than that, it doesn't have any bearing. Now, what was Shana's question? Because I saw part of it.
I'll read it out for you, David. So this person has said that they have a disability and they're autistic, and they found it hard to get vaccinated, and due to their complex health conditions, they have been very sick, and it's flared up since the vaccination. So I guess...
I'm going to say that it's not to do with the autism. I don't know what the other complex comorbidities are. And that would be a discussion for that person to have with their general practitioner or their specialist.
Yeah.
But my 14-year-old granddaughter, autism, had that vaccination. She's double dose Pfizer, no problem. But I don't know what the other comorbidities are around the health structure of this individual. So it really is talk to your doctor or specialist.
Okay, thank you. And thank you to the person who's popped a comment in around Star Health's Rainbow Tick Roving Star program that is providing vaccinations for people without a Medicare card at various locations around the city of Port Phillip and Stonington, and to go check out their website at Star Health. And we have one other question here. If you are HIV positive and your viral load is 0, where does that position you in the at-risk spectrum?
Probably if you've got an undetectable viral load that's sustained and your CD4 counts or your immune system, so your white cells are adequate, you're probably actually not at an increased risk category, broadly from COVID, and probably very similar to people who are not HIV positive. With the initial sort of vaccine rollout, anyone who was HIV positive was put into the kind of at-risk group, which I think is, when they're making the decision as to sort of who gets the vaccine, that sort of can be, I suppose, a difficult sort of criteria to develop. And anyway, and I think that just sort of saying anyone who's HIV positive was eligible is reasonable. It's a bit broader now, with everyone sort of being eligible over the age of 12. But so your risk from COVID is probably no greater than someone who's not HIV positive if you're undetectable and have adequate white blood cells. But so that doesn't mean that you've got no risk if you get COVID, because everybody is at risk of serious complications from COVID. It doesn't matter about your health status. So you're as at risk as sort of general population.
Yeah. Thank you. And thanks again. Yes, it's correct. There's a comment there. Your community health will be providing vaccination clinics with Thorne Harbour Health and also the Positive Living Centre in coming weeks. So stay tuned for that. David, I've got a question for you. Because you're living in a regional area, aren't you? So if a person is living in a rural or a regional community, where can they get vaccinated? Or are all the vaccines going to the city?
No, look, all the regional communities that I'm in, the local health services, and they're starting to roll them out in some of the pharmacies, some of the general practices. If you really don't know, most of the health services in each regional community, if you ring them up, they will tell you where the vaccination centres are. And pretty much all of them are doing have vaccination hubs. And there's quite often more than one. If you're out and you can't find the local one, ring up the Aboriginal service and they'll tell you they're pretty good with information.
Okay, that's
and
great.
They tend to ask a lot of questions as well, which some of the mainstream stuff do, which is even better sometimes.
Excellent. And thank you. Someone's put in the chat as well. There's further information, particularly for people living with disabilities. Just go to the coronavirus website through the Victorian government, which is www.coronavirus.vic.gov.au. And there's vaccination information there for people with disabilities. You can also request a disability liaison officer. So that's very helpful. Thank you, Alison, for that.
I want to chuck in there Alison's comment as well. I think, look, this flows on to regional communities. If you've got any doubts about who to see, where to talk to, ring up or go in and see the hospital liaison person, the Aboriginal liaison, mainstream liaison, health service liaison. They're really, we quite often don't think about using the health service liaison people. And they're pretty up to date and pretty good at pointing people in the right direction.
Fantastic. And a shout out to Ada Castle out there, who's a rural COVID vaccine ambassador, who's helping behind the scenes with me with these questions. Do keep them coming through if anyone has any further questions. But this is the real key here, I guess. It's around people working through what their lack of knowledge is, or what their fears are, or discomforts, and spending some time doing some research in the right places to get that evidence-based information, booking an appointment with your GP, and talking through with your GP who has a good understanding about your health and well-being, to talk through any risks with you directly. But this is sounding fairly positive, all around in lots of ways, that the risks are fairly low for lots of people. And these questions have been fantastic. The answers are really hopefully helping people get a better understanding around their personal situation. And if you do have any COVID vaccine hesitancy, we hope that this has helped you this evening. And we do encourage you to go out and find some information where you trust that source, and ensuring that it's evidence-based. Is there anything else that the panelists want to comment on, David?
Jeremy, and Nate can help me out here too, I think. Look, and I never get all the acronyms right, so I apologise, LGBTIQ, and I lose track after that.
It was great.
But, and I have, in my family, something like 70% of the females are gay, so I have it around me all the time. But for those people who know Indigenous people who are gay, have the conversation around the vaccination, because unfortunately, in a lot of the Indigenous communities and populations, being gay is still on the outer. We're probably behind mainstream a lot in that area, and it depends which state you're in too, but it can be still a big problem. So if you know somebody who's Indigenous and they're gay, and have the conversation around that, they can go and talk to the clinics and that, because it's not a shame job.
Yeah.
I don't know if you want to jump in there, Nate, with that. But.
Yeah. Have the conversation. So find your local community health, your local Aboriginal health service, your local doctor. Have a chat with them if you've got concerns, and encourage vaccination.
So I'm pretty keen on the vaccine. I'm very, very happy that I've got it. I just have to say, a huge amount of relief just was lifted off my shoulders as soon as I became fully vaccinated. And if anyone is tempted or interested in getting vaccinated, you can book in now. You can go to www.coronavirus.vic.gov.au to book your vaccinations, or you can call 1-800-675-398. That number again, 1-800-675-398. And yeah, so thank you all. Do we have any further questions? Do ask them now. Or any other final comments around perhaps those of you working with clients in healthcare services, do you have any positive stories, obviously de-identified, that you can share around how you maybe supported someone who was slightly vaccine hesitant?
I mean, I think that there's been a few, it's been sort of a very evolving kind of thing around people feeling a little bit reluctant and a bit hesitant, particularly when the vaccination stuff first started rolling out. There was the kind of surge of people wanting it, and then everyone kind of became a little bit reluctant. But I think that, we're now kind of at a stage where a lot of people who were initially quite hesitant are coming forward and saying, look, I was feeling a little bit unsure about it. I've had a few conversations more recently with people saying, I thought I would book in an appointment with my GP because I've been reading stuff on the internet and I've just decided that I just need to actually get some facts from a health professional. And so it's been really, really encouraging that I think more people are actually reaching out to their healthcare providers to actually get information. And I think that the internet is a black hole, and it's great to be interested in your health and research and all of that sort of stuff, but you can find whatever you want to find on the internet, and sort of making sure that you're talking to people who you trust, talking to people who have your health, are aware about your health needs as well is really important.
Look, I think that's spot on, Nate, because we can look anything up on the internet, and most of the time they tell you you've got bubonic plague and you're going to last 2 days. But there's a lot of sensationalisation in the media and a lot of the misinformation on Facebook and stuff like that. And I think we need to now get past that and start to really ask for the information and the data of what, as Ada's been saying and Nate's been saying, and that COVID's worse, the disease is worse than the solution. And I think that's the big push point, is the disease is worse than the solution.
Yeah.
And I think there's an interesting sideline that if we look at the 2019 flu epidemic, and there was about 100,000 cases of influenza in Australia and 3,000 people died. And then in 2020, a friend of mine's a pharmacist, he hardly sold any over-the-counter cold and flu medication at all in the 2020 flu season, because everybody was social distancing, washing their hands, doing things they hadn't done for years, and getting vaccinated with the influenza as well, because they all thought that might stop COVID. So it's just, we really need to, as Nate said, talk to health professionals and get the real story.
That's right. I don't think there's any kind of hidden agenda here. This is a genuine public health pandemic and crisis, and there's lots of evidence to support these vaccinations are the best way to address this head on. And for those that registered tonight, you will be receiving more information, probably through to your email. And there's also a coronavirus info hub for Aboriginal communities. So that's at VACCHO's website, so www.vaccho.org.au. If there's no other questions coming through, I just thought maybe we could spend a couple of minutes on any reflections or any final words of encouragement for anyone who might be watching tonight. Well, my words of encouragement are go get vaccinated. Don't be afraid. Like I said, my side effects were so minimal. I think, to be honest, I've had hangovers that were worse. I just want to encourage those of you who also are experiencing any isolation, or your mental health is being impacted by this pandemic, which is completely understandable. This is an incredibly distressing and difficult time. Everyone's feeling really fatigued at the moment, but everyone's doing a fantastic job. And if you are feeling like you are in need of support, you can contact Switchboard Victoria and QLife on 1-800-184-527, and they also have web chat available. And there's other supports available as well, but do recommend booking an appointment with your GP if you're at all concerned about any information or education that you want supported. And also there's also Rainbow Door that's available, so that where Rainbow Door could provide warm referral to services, and also to support you individually if you have anything happening in your life that you feel you need some support for. And whilst we're in lockdown, just want to reiterate that one of the reasons that you can leave home is also if you are at risk of violence and you're in danger of any kind, then you absolutely can leave home for that reason as well. And the Rainbow Door website is www.rainbowdoor.org.au. And if you require additional support at all, Rainbow Door and qlife.org.au. So thank you, Switchboard and Rainbow Door, for sending those information through.
Jeremy?
Yes.
Which website are you putting the recording up on?
Probably through Thorne Harbour Health's Facebook page, I'd say, and potentially to Switchboard's Facebook page. And it'll be on Facebook and YouTube. Thank you. And Thorne Harbour Health's Facebook and YouTube. Yeah. So check out Thorne Harbour Health's Facebook and YouTube to watch this, and then you can continue sharing this, because this would be a great video to also send to anyone who wasn't able to see it, to share it through your networks, just so everyone can be a part of this conversation and to hear all the information that was shared tonight. But if I can, on behalf of Thorne Harbour Health and Switchboard Victoria, thank our guests this evening, including the presentation by Dr. Jessica Kaufman, Dr. Ada Cheung, Dr. Nate Reid, and David Copley, who I used to actually sit across the desk from Jethro, and I also used to work for Quick Victoria, so we can catch up and have a yarn about that sometime. And thanks to everyone working behind the scenes to bring this together, and to all of you who tuned in to pay attention and listen to our panelists. Thank you so much.